for the opportunity to present on the publication on cervical cancer elimination in Africa. Where are we and where do we need to be? This publication was developed with IARC and the AFCRN. I'm going to briefly present to you the rationale for the publication, the chapters, and the key recommendations at the end. I do hope that you use this book in your countries and share it with program managers and policymakers. So these are the various chapters that I will quickly go through, and I hope that this information is useful to you, but please do go to the more detailed information in the publication. So, as many of you know, in 2020, the World Health Organization approved a strategy at eliminating cervical cancer worldwide within generations. This global strategy identifies the following threshold: that cervical cancer would no longer be considered to be a public health problem when all countries reach an annual incidence rate of 4 cases per 100,000 women or less. And this should happen within the lifetime of today's young girls. As no one intervention alone will be enough, the elimination strategy is based upon a 3-pillar approach that requires accelerated action in prevention, screening, and cancer management. So that includes the HPV vaccination, screening and early treatment of precancerous lesions, and prompt referral for treatment and palliative care of invasive cervical cancer. So the efforts are really focused on the 90-70-90 targets, whereby 90% of girls would be fully vaccinated with HPV vaccination by age 15 years. 70% of women are screened with a high performance test by 35 and 45 years. And 90% of women identified with cervical cancer disease receive treatment. Reasoning behind the publication was that the cervical cancer burden is high in Africa, and it's important to track what is currently in place to meet the targets and how these can be monitored to reach the elimination goal. So each chapter describes the current situation, starting with epidemiology and progressing through an overall assessment of prevention, particularly HPV vaccination and screening, and treatment and palliative care. While the chapter does lay out the coverage of the key interventions, we wanted to look at the data systems in place or required to track progress against the cervical cancer elimination targets across the African region. So, in a sense, we wanted to cover more than what we already know about cervical cancer in Africa, but look at what do we need to know so that we can plan for better coverage and uptake of interventions, and that we have an efficient data system as part of the elimination efforts. In the epidemiology chapter, we highlight how population-based cancer registries provide data on incidence and survival, and as such are key to tracking progress to reaching the overall target of elimination, i.e. an incident rate of 4 per 100,000 women. The data included in this chapter illustrates that this will be a major undertaking in that cervical cancer incidence rates are increasing in many countries in Southern, Eastern, and Western Africa, and these are among the highest in the world. And there are increasing trends in several countries. A key message in this chapter, which I'm sure will be seconded by all of you, is that we need to improve national surveillance systems, particularly cancer registries, to support the scale-up of interventions, and we need to monitor their impact. Staging information is critical, and the chapter talks about the importance of recording stage of diagnosis as a key indicator. The review of data found a lack of cervical cancer staging information in the region, and this is an urgent need to be addressed. Not only because lack of staging information leads to the inability to properly diagnose and treat cervical cancer patients, but also because we cannot measure the impact of cervical cancer interventions. The Essential TNM system is recommended here for cancer registrars. A material about Essential TNM is available on the UICC TNM web pages. In terms of screening, in most African countries, the biggest challenge in achieving the targeted 70% coverage of screening is the absence of a national cervical cancer screening program. In 2019, WHO had conducted an NCD country capacity survey. And in this, 20% of countries reported having a national cervical cancer screening program, and almost all of these programs were opportunistic. Clearly, this is a very low number, and we have to increase the number of countries with national screening-based programs. Given the heightened risk of HIV-positive women of cervical cancer, this necessitates prioritizing cervical cancer screening among women living with HIV, and we must do more to integrate cervical cancer prevention and screening with HIV programs. Encouragingly, there are discussions happening around this with HIV program managers, including at the level of the Global Fund, WHO, and others, to reduce the siloed approach to cancer planning in countries. The key point the chapter makes is that for screening services to translate into reduced morbidity and mortality at the patient and population levels, strong linkages must be established between screening programs and referral to diagnostic, treatment, social, and palliative care services. The treatment chapter covers various modalities, so it's quite broad and difficult to cover all the key points here, so I will just highlight 3 key issues. What it notes is that there are a number of gaps in terms of the chemotherapy, surgery, and radiotherapy modalities. Treatment options are limited in the region, largely due to the late-stage presentation of cervical cancer cases, and in many cases, when offered, therapy does not have curative potential. There are therefore several recommendations in the chapter regarding strengthening treatment and palliative care. Palliative care is also very limited, and there is a recommendation to develop a basic palliative care package, which includes access to pain medications. In terms of data here, we need a much better system that links information from screening, diagnostic, and multiple treatment services at the health facility and population levels. Finally, the publication recommends a number of policy recommendations, and these are the following. You can see them all here, so I'm not going to read them line by line, but basically they talk about the importance of including cervical cancer services across the continuum in the package of UHC. They include the importance of a cervical cancer control strategy in an NCCP, the National Cancer Control Plan, and really developing a strategy that addresses the elimination pillars that is costed and budgeted with funding available for operationalization. And that's really what we have seen in a review of NCCPs more broadly, but also in cervical cancer plans, that these do not have an adequate budget line attached to them. So without that, it's very difficult to implement these plans. Advocating for the inclusion of cervical cancer in the WHO Afro Integrated Disease Surveillance and Response Technical Guidelines as a priority disease for reporting. Using existing technical testing platforms for other diseases, so HIV and TB, and also using some of the developments made during the COVID-19 pandemic, so expanded molecular diagnostics, electronic disease surveillance, the use of telehealth and mHealth to improve cervical cancer screening and management and surveillance. And the integration was mentioned at length in the chapter on treatment, the importance of looking at how do we integrate cervical cancer secondary prevention, but also treatment and palliative care into other health programs, those being at primary health level. So for example, adolescent health, maternal health, sexual and reproductive health, and also HIV and TB programs. I mentioned earlier in the slides that HIV positive women are at higher risk of cervical cancer. Exploring pooled procurement in the region for diagnostics and treatment technologies and medicines, and considering public-private partnerships for treatment of invasive cervical cancer. We need to strengthen adolescent and school health services to increase uptake of HPV vaccination and also raise awareness of cervical cancer. We note from UICC members in the region that there is vaccine hesitancy. How do we overcome this? How do we look at changing the narrative on cervical cancer so that we can move away from some stigmatizing language related to risk taking, such as sexualizing HPV and talking about multiple sexual partners, which there may be some, of course, evidence from an epidemiological risk reduction perspective, but do not translate well in the lay language. And I think we've been talking about how do we, in a sense, desexualize conversations around HPV. So that is something that certainly advocates can work on doing in their settings. So here are some other recommendations that we've put to transition from BIA and pap smear to HPV DNA testing, following WHO guidelines, and improving access to oral morphine and adopting a minimum palliative care package, as I mentioned earlier. Our points really at the end are focused on the strong information management system, so investing in and establishing the cervical cancer screening registries, building the capacity of cancer registries to collect stage data, and very importantly, ensuring that cervical cancer screening and treatment information management systems are interoperable with population-based registries. So thank you very much. I am sorry that I can't be with you in person. Wish you a very successful meeting, and please do look at the publication and share it with your networks. UICC, AFCRN, and the IARC will be exploring more on how do we operationalize our recommendations, and we are always interested in your feedback on the publication. Thank you very much.